Back in 2018, we published a study which looked at giving immunotherapy to patients prior to surgery for stage 1 to 3 non-small cell lung cancer. Non-small cell lung cancer is the most common type of lung cancer. And for many patients who have surgery for earlier stage lung cancer, they will still experience relapse of the cancer after surgery. So the idea of giving immunotherapy prior to surgery was with the goal of exploring whether it was active in that setting, and also in the longer term, whether it could benefit patients in terms of preventing relapse. And in that study back in 2018, we showed that about half the patients had a major pathologic response where 90% of their tumor regressed after 2 doses of treatment. So then we designed the current study, which is called CheckMate 816. This was a randomized phase 3 trial conducted across the world, enrolled over 350 patients who were randomized to receive either a control arm of standard chemotherapy, platinum-doublet for 3 cycles prior to surgery, or the investigational arm, which was giving Nivolumab, which is an anti-PD-1 immunotherapy, concurrently with the chemo, and comparing those 2 arms and trying to show a clinical benefit. The primary endpoints of the study were pathological complete response, and the second primary endpoint was event-free survival. And this past weekend, we reported the results for pathological complete response. So this was a randomized phase 3 trial, fairly pragmatically designed, enrolled patients with stage 1B cancers measuring 4 centimeters or greater, stage 2 and stage 3A. And those patients were all rigorously staged and then enrolled in the trial and randomized to one of the 2 arms. They had the 3 cycles of chemotherapy plus or minus Nivolumab, went to standard surgery, and then post-operatively they could receive the investigator's choice of further therapy in the post-operative setting. And as I said, we evaluated the surgical specimens for pathological response. That was done by a blinded independent committee of pathologists who did not know which arm of the trial the specimens came from. And in the longer term, we're still following those patients for event-free survival and for overall survival. We saw that when the study was evaluated for the pathological complete response endpoint, which we made the final report of just this last weekend at the ACR meeting, there was an improvement in pathological complete response from 2.2% with chemotherapy alone to 24% with chemotherapy combined with Nivolumab. And this was a significant improvement, as you can imagine, a greater than 10-fold increase in pathological complete response. We also saw that there was no impact on the feasibility of surgery by the addition of Nivolumab to chemotherapy. And there were the same or lower rates of toxicity when you added Nivolumab to chemotherapy. So both of those 2 findings were also important because we showed that there was no negative impact from adding Nivolumab to chemo. And there's potentially a very significant improvement in pathological complete response from the addition of Nivolumab. We're continuing to follow these patients for longer term survival outcomes, but I think these are very promising results at this point. We also did some correlative analysis and looked in particular at circulating tumor DNA levels in the blood, a technique called liquid biopsies. And in a subset analysis, we were able to show that there were higher rates of clearance of circulating tumor DNA from the blood in patients who received Nivolumab with chemotherapy. And those patients who did clear circulating tumor DNA prior to surgery were more likely to have a pathological complete response. So I think that's an interesting subset analysis, and we hope to explore it further. Yeah, so we'll be continuing to follow these patients. The the timing of follow-up for event-free survival is event-driven, so it depends on how quickly events occur for patients who were enrolled in the trial, but we'll be following them closely, and we hope to report the results for longer-term survival outcomes in the near future. I think this is potentially a very important advance for patients with early stage lung cancer. We haven't seen any advances in terms of immunotherapy for early stage lung cancer so far, at least reported. And I think a neoadjuvant study also highlights the potential for neoadjuvant clinical trials to drive progress for cancer in general, where you get an early endpoint in terms of pathological complete response, and then the patients can be followed up for longer term clinical endpoints as well.